Assalamu alaikum, Dr. Mazen, dear group. I am ready for live. Are you ready now? If you hear my sound clear, just tell me. We start our lecture today. It's about very important issue. It's about the early detection of oral cancer. I think we are, as a dentist, it's very, very important and very, very crucial to create smile. We like to create smile and we like to save our patient. We don't like to kill our patient. This is my resume. Before I start, I don't have any conflict of interest and no momentary benefits from these lectures, and there are no direct implementing as any sponsoring for me. I take the consent for photography for this patient. This is very, very crucial issue. It's very old name, cancer. Cancer, it's very old name. It's described in a lot of cultures, in Egyptian, in Indian, in a lot of cultures. What's mean of cancer? Cancer, we eat cancers like this. Cancer, it's mean that they are describing certain skin tumors. It's like cancer, and say if this is if left without treatment, it can kill the patients. Usually we can see some cases like this. I think it's very rarely to find a dentist didn't see a case like this, like tongue, like these ulcers, like these lips, and like this wound unhealing, or the patient came to your office with wound and the wound didn't heal. Okay, I don't like to see these cases. Unfortunately, I see some cases like this in my practice and in my life. This case, it's lifted and neglected cases. The patient came to the dentist and the dentist couldn't advise, just prescribing antibiotics and mouthwash and something like this, and wasted a very, very important and very important time to save the patient life even. The incidence of cancer is still, luckily it's not so high, but the most important and annoying thing, the survival rate, it's very, very low, and the patient can die easily from this one. Okay, if you have early detection, you can increase the patient chance up to 76%. If it metastatic, what's mean by metastatic? It's mean transfer to another place. Usually, in a tumor can be transferred to another place either by blood or with lymph nodes or to the neighboring tissue or via celiac transmissions or even via nerve. Later, we are going to discuss the role of metastasis and how we can help our patients. Early detection, you can save the patient, and very important if you have tissue change. In this lecture, we are going by the examinations and what's the red flags to help our patients. The staging statistics for oral cancer, the one person die from oral cancer every 1 hour, and the mortality rate is still so high. Public awareness is very, very important, and awareness of something like human papilloma virus and EPV virus decreased dramatically. Also, a very important issue regarding to some bad habits which increase the incidence of cancer, like smoking and alcohol drinking. Let's see this brief video. It stated how we can help our patients to decrease the cancer. Oral cancer, we have to study this. Why? Because it's 6th commonest tumor in the body. So this the universal issue, but regarding some countries like India, it's considered the second one. So you cannot neglect it. Usually the cause of oral cancer, it can be avoided, like alcohol and drinking and smoking. If you lead a healthy life, it can decrease the incidence for oral cancer. Also very important, you have to get a checkup to avoid costing. In US, it's considering for 40,000 cases discovered per year, and this is considered a very high ratio. And the survival rate is half of them, they die after 5 years. And it can be metastatic and cause all of these cancers. 75% of oral cancer caused by lifestyle choice, like smoking, alcohols, or even sun exposure, especially for the cancer of the lip. When we stated oral cancer, usually we meant squamous cell carcinoma because it's encroaching 90% from the oral cancer. We have some warning signs. This is luckily like leukoplakia and erythroplakia. Leukoplakia and erythroplakia, it's not considered a disease. It's considered a clinical terms or clinical descriptions. We have other possible warning signs like lump. Lumpets mean thickening of the soft tissue, soreness or lump in the throat, difficulty in chewing or swallowing, ear pain. Why? Because we have ligaments attached to the mandible, maybe it referring pain to the ear. Difficulty of moving the jaw and the tongue, hoarseness of the voice, numbness of the mouth. Why numbness of the mouth and tongue? Because it may be encroaching the nerves and swallowing of the jaw. Risk factors, usually as we stated before, in tobacco use. What's the most common? Tobacco, the chewing tobacco, it's the highest, or like nicotine, gum, this is very dangerous. Alcohol use, alcohol, it's considered a carcinogenic because it's contained, like liquors, it's contained some materials carcinogenics, and even pure alcohols, it facilitate the result, it make a synergic effect with tobacco and increase the incidence of cancers. And one of the highest places in the earth in oral cancer is Brittany in France, because it's very famous with wine. Age also, it's a tumor of middle age. Gender, it's high in male. Race, it's more in Indians. Examination, very important. In this lecture we are going through the examination, head and neck examinations, and how we can take a history of this to follow up. Let's start now with the oral diagnosis. Oral diagnosis is very, very important. It's stated in the past that oral surgeon didn't make the patient grind in his teeth to see the occlusions, and the orthodontist didn't open the mouth to see a hidden oral cancer. We don't like to be like this. Actually, clinical pathology, it's a study of the change. So you have to know the normal before you jump to the abnormal. The dentist doesn't only treat the teeth in the patient, but the patient who have or not teeth. This is very important. I prefer to go to the algorithm when I make diagnosis of any disease. I have to identify the systemic disease, very important. I have to identify the drug and the medicine. It can give me a clue, especially if you have patient with treated oral cancer and receive bisphosphonates. Maybe you can get something bad if you don't know this. So you have to take care. We have to modify the treatment planning. We have to protect our patient. This is very important to get dental and legal standpoints. This is very crucial. You have to communicate with other medical consultants, and this is very important to establish a good patient relationship. Detection and examination of the lesions. We have to examine the lesions. How we can do this? We start with the patient. I have to listen to my patient. If you listen to the patient tell you his diagnosis. We have to re-examine the lesion. We have to classify the lesions. We have to list our possible diagnosis, and I prefer to write this in paper. And we have to develop differential diagnosis, and after this we can have some study, and till we reach the working diagnosis and final diagnosis. How to can confirm from our diagnosis? By some lab investigations like biopsy, we stated later on. And after this we are going for consultations. Either we are treating this within the facility, or we have to refer the patient for other consultants or to treat it in the hospitals. Oral neck examination, it's mandatory for oral cancer. I prefer to classify my examination into 8 steps. 8 steps. It's number 1. I call this extraoral assessment. This is very important. You have 2 eyes, so you have to look to the patient face, to the patient head and neck. Very important, and you have to notice if there are any abnormalities or a change in the skin. Color skin, it's mandatory. Why? Because now I'm jumping to something very important, what's called neck nodes. Neck node, it's mandatory to check the neck node. Why? Because in the first of my lecture I said something about the metastasis. What's mean of metastasis? Is transfer of the tumor cell into other places. It's very important. If we see this is my aim to check something. It's called lymph nodes. Lymph nodes, it's carry lymph. If we have more, something like infection, something like surgical edema, this lymph node have swallowing. If you have something like cancer, this can be hard. So we have to examine this lymph node. It's very crucial. In neck, we have 5 zones of this. And we have very important to approach to the supraclavicle. So usually very important to ask your patient to show his neck. This, the nodal network of the body, it's very important. Lymph node, you must concerning this. And if you see this lymph node, it's spread all over the body. So, what the function of the lymph is to clear the infections. And also it's helped dramatically in the immunity of the body. So, in some viruses like human papilloma virus and EPV virus, it implementing the immunity, so it can encroaching with some cancer like ABV, it's encroaching with tonsillar carcinoma. Okay, at first I like to make neck exposure to my patient, and I like my patient to be seated, relaxed, and neck exposed from the jaw to the clavicle. Why? It's very important to check if there are supraclavicular lymph node. It can be a sign of cancer to the, it's very important, it can be a sign of cancer to the thyroid. And very important issue, don't jump to make a bilateral examination of the neck. Maybe good push to the bilateral carotid, what's called this sick sinus syndrome, and your patient may be collapse. After this, we recommended to hold the head. I use my left hand to hold the head, and I try to examine the lymph node against the bone. I start to examine submental triangle, what's called area 1, and then followed by submandibular triangle lymph nodes. And for the facial lymph node, we go for the parotid tail, parotid gland, preauricular and postauricular area, and occipital area, both sides. This is postauricular area, and this is occipital area. It's very important. You have to palpate upper cervical jugulodigastric and mid jugulodigastric, and finally you followed by lower cervical nodes, what we call jugulo-omohyoid lymph nodes. And the posterior triangle, it's very crucial. This is a posterior triangle. If we discover neck nodes, maybe the patient later on, after confirming, we go for something what we call this neck dissection, and this increasing the difficulty of the surgery. How we examine the sublingual gland and submandibular, it's very important to do it by manually from intra and extraoral like this. Lips, you have to see the patient lips, whether there are a crust. Why? And if the patient can move the lips, this is very important. And you have to observe the lips of the patient. And you ask the patient to smile to check the cranial nerves. This is very important. Labial and buccal mucosa, it's very important. You have to check, I prefer to check from the midline up to the back. And also I check the parotid gland. I check the occlusions. If the patient tell me there are a disturbance in the occlusions, I check the tongue, and I check what this ventral of the tongue, and this area, what we call this coffin area. The most common site for oral cancer, it's tongue. This is number 1, and this is the most common area for oral cancer. Lingual and lingual pouch is very important, and this neglected area, unfortunately, it's not focused by a lot of people. Step 3, lateral border of the tongue. I use a gauze to hold the patient tongue, and then I go for my investigations. I prefer to start from the anterior up to posterior to avoid any gag for my patients. You ask your patient to open. Why? To check the palate if there are any numbness. The most common tumor in the palate is adenoid cystic carcinoma. You have to check the tonsillar base, and you ask the patient to swallow to see if there are any deviations of this area. Let's see this. If the patient complains of oral bleeding, it can be periodontitis, it can be hematoma, it can be erythema multiforme. If you have cases like this, what do you think about this case? We have redness, and around the redness there are white halo. It can be most probably leukemias. See this case? This case, it's most common in Indian patients. This is from petal nut chewers, and this usually you find this in Indian and Pakistani patients. We call this masala strip. This verrucous carcinomas and different form of oral cancers. This it's associated with cigarette smoker. After you develop the diagnosis, develop your working diagnosis, you have to confirm. How we can confirm? We have to perform something. It's called biopsy. What's mean of biopsy? Biopsy, it's mean that I take something from the living tissue, and after this, I will ask the histopathology or oral pathology specialist. He will do examination for this based on some stain to give me my microscopic diagnosis. Very important issue, human papilloma virus is associated with oropharyngeal cancer with or without risk cancer of tobacco or alcohol use. This is human papilloma virus. It's also in the female, it's associated with cancer of the cervix. Why this virus cause cancer of the cervix? Because it will cause some mutations of the genes like this. So it's very important if you do lasers and you have pregnant, if you have lady in the childbearing age, you have to ask her to take a vaccine against human papilloma virus to help our patients. Very important. I don't like to go for deeply in histopathology. If you see this diagram, we have basement membrane in the oral cavity. Our mucosa is stratified squamous epithelium, and we have this basement membrane. This is the most important things. If this basement membrane is intact, this means that you are working with something pre-malignant. If we have invasion for this basement membrane, it can be indicated to the invasive squamous cell carcinoma. So we have to look about what's mean by cancer. The philosophy of the cancer is called dysplasia. Dysplasia is abnormal form of the tissues. So if we can detect this basement membrane, thus we can make diagnosis for oral cancers. So the most recent things, we can use something like fluorescent to make proper diagnosis. This is machine, it's used for diagnosis of oral cancer. If we have suspicious, we use this blue light, and based in blue lights, we can make a proper diagnosis. Let's see this cartoon. These bad cells here like this. If we get a fluorescent light, these mad cells, it's cancer. And usually cancer is considered a disease. Why? Because usually we have what we call tumor necrosis factor. If you don't have tumor necrosis factor, you become more susceptible for oral cancers and different types of oral cancers. So if you are heavy smokers, as we stated before, that 75% from the factors of the oral cancer, it can be avoided, like human papilloma, like smoking and alcohols. Human papilloma virus, see, this is a tongue, the most common site for oral cancers. And also this machine, it get the fluorescent light, and if you have abnormal light, not red, this means indicated something susceptible, as we stated later on. And we see how we can use this machine in treating some cases. So, see here, we see something weird. So, by using this fluorescent light, you can discover some oral cancer cases before even it become clinically obvious. Like this case, it's easy to discover this for your patient. See, this is normal oral flora. Here we have obvious dysplasias. See, this fluorescent. Now we don't have a very beautiful fluorescence, it's lost here. This indicated of carcinoma in situ. So usually if you have this case and make it treated rapidly, you can help our patient and save their life. Like these cases. This is severe dysplasia of the alveolar ridge. Very important to ask if there are something. If you have this dysplasia came to your office, you have to ask the patient if there are any problem, any trauma, any things. If the patient come with trauma, I ask the patient, okay, come for me after 2 weeks and check if there are improvement or no. And also maybe it's severe dysplasia, it's indicated for biopsy. What do you think? It's better to observe or to refer? If you have severe dysplasias, it's indicated it's better to do biopsy to confirm, to help our patients. This is moderate dysplasias. See, this dysplasia, it's coated very, very early and discovered that's carcinoma in situ after the biopsy. Like this case, also it's squamous cell carcinoma, it's discovered subclinically. And also to help us for pre-clinical discovery, like these patients. This patient is a high risk, he's a smoker. Usually we do this assessment every 6 months when we do a proper checkup or recall for the patients. We can use a probe to check if there are any problem. What's mean of biopsy? Biopsy is mean surgical procedures to obtain tissue from the living organism. This is the aim, to do a microscopical examination. Usually it's done for diagnosis, but it's very unethical to do biopsy. If you like to do a biopsy, you have to do two things, very important. You have to write a differential diagnosis. This is number one. Number two, you have basic surgical skills. Indication of the biopsy: if I have inflammatory change with unknown cause. For example, if I have patient with ulcers from dentures, it's not indicated for biopsy. I just ask my patient to wait and see. Lesions which interfere with our local function. Bone lesions, not specifically. Any lesions has characters and have susceptibility for malignancy, like this. I have some red flag. It can increase my susceptions for malignancy, like erythroplakia, ulcerations, especially if I have deep ulcers, durations, if the lesions last more than 2 weeks, gross rate. If I have lesions very rapidly gross, it's indicated something bad. If the lesion make bleeding or loosening of teeth, indurations and or metastasis. Fixation: if I have lymph node, it's fixed to the tissues. We have a lot of types of biopsy. The main types is number one, cytology. Aspiration, I use a needle. Incisional, I take a part from it. Excisional, I took it as a whole. Oral cytology, usually it's done for oral medicine. It's done for diagnosis to discover pemphigus vulgaris and mucous membrane pemphigoid, herpes. Aspiration, it's usually done for cystic lesions. Aspiration, it's done, very important to do this to check if there are this a fluid, not a blood. It's indicated. Incisional, it's mean that I take a part from the lesions. Why I do this? I do this if I have a large lesions. I cannot do it. I cannot remove it as a one whole, or I have malignant lesions, so I have to remove it with safety margins. Incisional biopsy, I have to fix my tissue and I have to take it from the most susceptible tissues. Indications: the lesion is difficult to excise. There are some places called contraindicated for taking incisional biopsy. It's parotid gland. Why? Because if you take the biopsy, you will get obvious scar, you will spread the tumors, and you will make infection to the facial nerve. So it's not incisional. We give the patient anesthesia. Like this case, we have very large lesions. We give the patient anesthesia. In that cases, I prefer to give the patient blocks. Why? I don't like to give anesthesia with this. In this lecture, I give the basic science for biopsy. Regarding to the biopsy, I prefer to use a laser, especially carbon dioxide laser. It's give me a very good result and decrease the bleeding. I take the biopsy from the most susceptible area. This is incisional biopsy. So I take a part and I have to write what I call this biopsy request. Biopsy request including the patient data, and also I write the patient data on this. Another way, it's called bunch biopsy. Bunch biopsy, we use a bunch, we use it in dental implants. And after this, we put our sample in. Usually you put it in formalin. Formalin, its concentration 10%. And the container, usually it's 10 times larger than the specimen. This is brush biopsy. Excisional, it's mean that I use it for small lesions or lesions I guarantee that it's benign lesions. Like these lesions. This is done with diathermy. Usually very important to make suction during using laser or using diathermy to avoid any tissue fumes from being inhalated. This can be lead for your assistant and for you to get human papillomavirus. So it's very important to provide a continuous suction during your work. Another important issue when you take a biopsy using lasers or using diathermy or monobolars or anything, you have to notify the pathologist regarding this. If you have a large biopsy, also it's better to mark the biopsy and notify the pathologist. This is anterior and posterior. Why? Because in some cases I ask my pathologist, number one, I ask my pathologist to identify the lesions. This is number one. And another things I ask the pathologist to check the safety margin and tell me if there are any safety margin or no. The principle of surgery, we give the patient block anesthesia, it's preferred. I will never inject directly to the lesions. Why? Maybe I get spreading. How we can stabilize the tissue? Either by fingers or with towel clips, like this lower lip mucocele. Also, we take a biopsy. It's considered from the lower lip. It's considered a diagnostic test for Juglin syndrome. Hemostasis. During hemostasis, we don't like to use sections. We use sections not from the site of the surgery. Gauze compress, it's very adequate and very useful. Like this case, small cases. Incisions, it's usually made with scalpels. Specimen, as we stated before, should be immediately placed in 10% formalin and completely immersed. The margin of the biopsy, it can be marked with sutures, with silks, and we write the biopsy report. Thank you for your interest. If you have any questions, I'd be more than happy to answer. Another important issue regarding these lectures, I will send you a link in the comments. If you go for the questions, if you pass these questions, you will get 1 hour from ADA SORB. It's help you to renew your license. Thank you so much for your interest.